This is Call the Psychiatrist. I'm Dr. David Handley.
And I'm Dr. Abby Snavely.
On this episode, Tess's psychiatrist made a significant disclosure in their final session, making Tess wonder if withholding information is necessary. Our second question comes from someone whose therapist visited her at work, leaving her feeling confused, especially since she'd like the relationship to be closer.
Say you like me, you better count the ways.
Listening to this podcast does not mean we have a doctor-patient relationship. Our intention is to educate and entertain you. Nothing we say is intended or recommended as a substitute for medical advice, diagnosis, or treatment. Always seek the advice of your own physician or other qualified healthcare professional regarding any medical questions or conditions. This first question comes from Tess.
I understand that a part of some types of therapy is seeing the therapist in the idealized state or as a blank canvas to be able to experience transference. In my experience, this has seemed to work against me. My previous psychiatrist disclosed to me in our termination session that she too had experienced an eating disorder. During our sessions, I held back so much information due to shame. If I had known she had a similar experience, I would have been able to completely open up. Is withholding so much information from a patient the only way to gain the insights that therapists are looking for?
So a plot twist in the last session.
I guess so. I maybe talked about that I always, for my own therapy, I always wanted a great reveal, but I don't think I ever conceived that it would come from the therapist.
Yeah, right.
Right? It's like, that's not the way it's supposed to go.
No, you don't have a series finale that makes you have to go back and question everything, at least not in therapy.
Right. This isn't The Usual Suspects or something, right? Like you have to, like, I don't know. I think this is bizarre. I mean, we're making all these jokes because, like, I don't know how to get into it because it's straight up weird.
Well, so I think there's several interrelated topics we can get through, and not just about this specific disclosure, but the timing, and that's the easy one. So why don't we do that one first?
Okay. The timing's bad.
It's not the appropriate time.
It's not. I mean, I would say it's not ideal, but I have a lot of thoughts on this, and I feel like I'm usually pretty good at kind of imagining different scenarios or where someone might be coming from, and I really can't think of a therapeutically informed reason that this would happen. The best I can come up with is that the therapist needed to get it off of her chest for some reason. But even up to the last moment and beyond, the needs of the patient need to come first. So, like, it still doesn't make it okay.
Any kind of disclosure should always be in service of the patient. And
yes.
You cannot, there's no way to extrapolate how this serviced Tess, because I mean, even if it was appropriate, which we can get into later, because there wasn't a chance for her to then process it with her therapist, with all this information. So it was all about the psychiatrist in this scenario. And I don't know why she would have done that. I mean, I know why she did it. It was for her own needs. I just don't know why.
Sure. We don't know any details about it, but there's no conceivable way that this was good for the patient. I mean, as Tess is saying.
Right.
But
as she points out. Now, patients can drop bombshells
all the time.
I mean, sometimes I think when that happens, it's an indicator that maybe the therapy is ending prematurely, especially like if there's some external factor that's causing it to end, and then they just want to get something off their chest there in those last sessions.
I think you're right. I think sometimes you're right. Either the therapy isn't done, or maybe it's something that the patient had hoped to get to that they hadn't been able to, at least with this therapist at this time. A little bit in that same way, I think I felt this pretty frequently, I guess, when I was a resident, and all of the terminations were premature, or at least, not coming to a natural end, that I felt that people sometimes wanted to say something that maybe if we were continuing in therapy, they might have brought up quite a ways in the future, but it's kind of like, I need to just say this to another person. I mean, sometimes it would be some disclosure of abuse or something they had done, almost like a confession. I think you're right, like a true kind of like getting it off your chest and leaving me with these, I guess, what kind of felt like secrets. And it's like, well, obviously we're not going to be able to deal with this. And I think maybe there's both a wish to have dealt with it, but also a relief that we didn't have to dig into this thing that was messy or painful. But they still felt like they had to say it.
Yeah, those external factors that caused it to end. I would see the same thing, like
Right.
if I've had a patient move away, or I had to move, or like you're saying in training, like you have to move on often prematurely. Yeah, so I don't know what the situation is with Tess, but
Doesn't matter. No, we're talking about all the reasons it makes sense from a patient standpoint.
Yeah,
because
right.
we have nothing to say about why it would make sense from the therapist standpoint.
Well,
if,
yeah,
they're,
'cause
if they're still doing therapy.
yeah, well, and she actually just harmed the work that they had completed. I mean, I was thinking how termination.
Yeah, good point.
Because it's, there's reflection and there's celebration and there's mourning, and it's hard enough to go through that without having to now go back and replay everything again with this new revelation.
Including the knowledge that something like this had been withheld the whole time. And I think you're right. We'll get to if the disclosure would have ever made sense. But I think you're right. It casts a light over everything else, including the kind of authenticity of that therapist in all sorts of moments, I can imagine, especially if the eating disorder was a focus of their treatment.
So Tess would argue, well, the disclosure would have been justified because it would have made me trust her more or feel less shame. So when I say a disclosure should be in service of, then she's saying, no, it would in fact have helped me.
I mean, I don't know. There's the bigger question of help that I'm really not sure about, that it would have been helpful. It could have been a way to reduce shame, but I guess I just have to believe that there is other ways to work through that shame without knowing so much about the therapist.
Right, like being in a relationship where you can talk freely about your lack of trust or your fear of shame.
Right. For example, and it's not just because you don't know everything about the therapist, because, I mean, just no one ever does, but in this kind of relationship where things are by definition not equal, the patient shouldn't know everything, even if it is a common, I guess, diagnosis or struggle.
This treatment probably ended too early, given that she was still holding on to that level of shame or that level of distrust.
Well, and I guess I wonder, I mean, she even says, I understand in some types of therapy. So I don't know if this was supposed to be a certain modality, or I don't know. It sounds like Tess had some ideas about maybe what should have been said or not, or what needed to be worked on or not. But I don't know obviously we don't know the parameters of that. But yes, in what I think would be an ideal or just a more complete form of therapy, getting to guilt and shame, getting to what makes things hard to say or what is being held back would be a pretty universal, I don't even know if I would say focus, but like a sign that things have resolved is when you can speak freely, right?
Mm-hmm. And I think I understand the allure of this fantasy that that our bond would have been better. But, it's an illusion. Mm-hmm. Her experience of her eating disorder could not be the same as Tess's.
They're different people.
They're different people. And so I think it leads you down avenues that end up actually showing even more differences. Because then you would want to know or need to know about the psychiatrist family and her support system. Mm-hmm. And I think you just uncover more and more things. It's like, oh no, we've experienced this very differently. And I think the similarities is why a support group can be powerful.
Sure.
All the participants struggle in their own way, but against a common problem. But a support group is not the same as having an effective therapist.
Yeah, I think that's right. And even if, the therapist and the patient have the exact same symptomatology, I guess I believe that our pasts, our families, like you just said, influence the expression of illnesses or pathology or symptoms, and that even the current symptoms that someone is struggling with exist in a context that is hyper-specific to the patient. And so I feel like having a similar diagnosis or a similar symptomatology is really the most superficial level of similarity. And that, yes, we're going for symptom reduction, but depending on the type of therapy, but if it's some sort of insight-oriented or dynamic therapy, you're also trying to understand where this comes from and the meaning. And so I think it could be very easy for one or both of them to over-identify or take shortcuts in assuming understanding when it's really not there.
You want the therapist to have some removal from the problem, so then the patient can remain the focus. And I would venture,
hope so.
that this psychiatrist actually struggled at times to make sure she wasn't over-identifying with Tess, or to make sure she wasn't projecting if she was, having trouble managing her own eating disorder. I think these are the cases where it takes a lot more mental work on the side of the therapist. Anytime we have experiences that are similar to patients. I deal with this on a weekly basis. Patients
all the time.
They have conflicted relationships. Sometimes the narrative sounds very much like my own, and sometimes it's the patient's narrative. But sometimes it's, I can identify with a family member or somebody that they're having the conflict with. But and I know I've said this before, but one of the most critical things a therapist has to do is to observe what they're bringing into the room and make sure it doesn't interfere with what the patient has brought into the room. And I don't think the commonalities need to be ignored, because it can give the therapist a lot of insight. But they have to be conscious of where it's coming from.
And how to acknowledge or not acknowledge it.
Right. And so I think that system can break down with these kind of disclosures, as you're saying, because then you start making shortcuts. You make assumptions about what each other, or what, in this case, Tess is experiencing.
Yeah, and sometimes patients might say, I'm struggling with depression. If I say, well, tell me what depression means, they are likely, maybe not likely, but sometimes people will say something like, oh, really, you're a psychiatrist, you don't know what depression is, or like, how it is. And it's a lot easier too, I think, to be like, well, I don't actually know what it means for you, especially if it's not like, well, I know what it means for me and I know what it means for other people. Like it gets, I think, unnecessarily complicated. And I don't know. I think that if Tess had said, I terminated this treatment and then I ran into my old therapist at a support group, oh my God, I can't believe she never told me, then again, we could understand. So I understand the not direct disclosure throughout the entire treatment until this last session, right? We don't know what was resolved. We don't know if Tess felt like her symptoms went away. Obviously her shame didn't go away, but the withholding up until the end makes perfect sense.
Except that she finally disclosed.
I know, that's what I mean. And
Right.
and I'm sorry, and I actually should rephrase it, because I don't think it's withholding, right? A thoughtful abstinence is maybe a better way, a therapeutic, keeping the focus on the patient. Yeah, that's all justified across the board.
I'm sure there were so many times throughout the treatment that the psychiatrist wanted to reveal it. The fact that she
I'm
ultimately
sure.
did tells me that she struggled with this probably for a long time and thought it would. She probably had a judgment that it was ultimately not in Tess's best interest, so that's why she didn't mention it.
But I also wonder if the therapist didn't feel like getting into the details and didn't feel like she could or was confident in keeping some of that under wraps. I still think that, that argues for not saying it at the end. But I think there is a way to say, from the therapist standpoint, to say, I understand this from personal experience, but then still setting boundaries about how far you get into the details there. I've been in therapy. I've struggled with these same things, right? I mean, that kind of thing, without saying a lot of specifics, or if there's, regional or cultural things, it's like, I have some familiarity, but I want to know what it was specifically like for you. Yeah. Or if there's something the person knows you have in common, being really explicit about, I want to be careful to make sure that neither one of us assumes too much. And so I think we should, again, get very specific about what it was like for you and what the meaning was for you, because so much of it could look the same.
Yeah.
I think there's also a risk of not giving, which I guess Tess alludes to, not giving the patient, someone to idealize, but maybe more importantly, someone that they can believe maybe has it together a little better than them, right? Mm-hmm. In some way. Someone who has an authority or, has done the work, whatever it is, and is in a better position than they are. I think that disclosing one's own illness or struggles can also put a burden on the patient in terms of making sure the therapist is okay, or wondering about what's going on with them. And I think that is ultimately just not fair and a disrespect of the therapeutic relationship. Is withholding so much information the only way to gain insights? No. The answer is no. That was her last question.
No, you can have a completely different modality of therapy. Like it doesn't have to there's a lot of different ways you can get benefit.
Maybe this is also too far afield. It's like, well, gain the insights that the therapists are looking for. I also think that, and anybody who's been a parent or tried to give advice in general probably knows this, that usually the patient, the child, the advice receiver it's going to be more meaningful and more helpful for them to come up with things on their own, or at least feel like they have come to something that makes sense for them and not for somebody else. And so I guess the alternative to the setup here feels like well, I've been through this and here's my advice and here's the steps you take, which feels like it could just be kind of reduced to an Instagram account. And then it's not really therapy, right? It's like it's self-help or advice.
Or peer support.
There's plenty of it. Yeah, or peer support. There's all kinds of stuff for that. And so I guess I just feel like it's something different. And I'm sorry that Tess was hurt by this, and I'm sorry that it was confusing. But it also, I guess as she goes forward, I hope her next therapist, if she decides to keep going, is someone who she can talk about this with. And if there are things she's feeling shameful about, or feeling like she needs to withhold, or feeling like the therapist is withholding, that they can talk about that without gratifying this wish right away, because I think it does foreclose a lot of insight and reflection and specificity that Tess could benefit from.
All right, Tess, well, I hope that's helpful. Thanks for the question.
Yeah, thank you.
We got a review from Georgia W., a treat for fellow therapist. I really enjoy listening to this dynamic duo on my drive to work. Thank you. I discuss your show with my supervision group and clients. It's helped me refine my personal approach to therapy. Thank you so much for taking the time to leave a review. It really means a lot.
Yeah, and for spreading the word. We appreciate it.
And this question comes from Lilith. I just listened to your show about the therapist who is hiding from her client. I have the opposite problem. As background, in early 2021, I started meeting with my therapist, and we were doing in-office sessions. I ended up feeling really close, and like I finally had someone to confide in. About 6 months later, she unfortunately had to move offices. It was a tad far away, so we changed to meeting online, like on Zoom. I haven't seen her in person for 2 years, until this week. Recently, I told her I got a new job at the mall in a department store. A few days ago, I turned around and she was there with her 1-year-old baby. I was genuinely shocked when she came up and said hello to me while I was doing my own thing. When I turned around and saw her, I couldn't help but smile. I was so happy. It felt kind of like picking up a family member from the airport. I still can't believe this actually happened because I really thought I might not see her in person again. It was just a quick interaction. Hello, nice to see you. And I got to meet her baby, which was super cool. But now I'm feeling confused. The problem is my attachment, which is really strong. I know it has to do with my transference to her. I'd like her to be a part of my family or a friend. I really would. When she stopped by my work, it all feels a little too close to the reality I want. I don't know what to do. I know you're going to say I should talk about it, but I don't know. I'm such a cliche.
Oh, Lilith, I feel for you. I don't think she did anything wrong.
Oh, no, Lilith didn't at all.
Or is doing anything wrong, right?
No. Her therapist clearly doesn't abide by the same guidelines we do.
No. The problem is that, we will talk about all the permutations as always, but the actual problem is the surprise, right? The surprise on one half of the equation. Running into patients as a surprise to both of you, we have talked about. This wasn't it.
Right. Pursuing you at your place of employment, that's different.
Right?
I want to just do a quick summary because she referenced
Please.
episode 40. We said these encounters can be hard for a couple of reasons. One was it could undermine the patient's privacy. And then two, that it could cause some distress because you're potentially put into a vulnerable or regressed headspace when you weren't expecting it, when you're surprised with it, as you said.
Ring-a-ding-ding.
But I think Lilith is bringing up another good point, which is that it's confusing or disorienting.
Yes.
Very similar to the way boundary crossings make people feel.
You might even say this is a boundary crossing.
I know, right?
I mean, you really tossed me a softball there, boss, but...
Well, when I first read it, I didn't think of it as that egregious. But then when I thought more about the effect it had on Lilith, I don't know how else you can interpret it.
How do you want to start? I was going to say, we could do, as we sometimes do, trying to think of details that would make this more okay, right?
I always do the same thing. I always start
Yeah.
with like,
It's a point of generosity.
well, just that I assume intentions are pure. I always
Right.
think of the best case scenario, where this just happened to be a one-off. And so in that scenario, I've got Lilith in a specialty department within the store, and that this therapist has to have something in that department that she cannot obtain anywhere else.
Right.
And so
right.
it was inevitable that they were going to run into each other. So she approached her at a moment when she could tell that they would be alone. But, there's just nothing in the question to support this.
And
Like,
they
I'm not gonna do a lot
obviously
of
live
conjecture.
in a part of the country without internet access. So the therapist does not shop online, but they still have a mall. It says the mall, so maybe it's a small enough town where there's one mall.
Well, but they're far enough apart to move to online treatment.
David, we are
I know.
doing
This is the
the
good
best
version.
case scenario. This is the good
Okay.
version.
Okay.
Maybe, the therapist is sleep deprived because she has a new baby and she forgot that the patient works at Macy's and not Nordstrom and got him confused.
Okay, you're doing a lot of work now. Yeah.
I'm doing a lot of work. So it actually isn't that great, it turns out. Right? I mean,
Yeah. So then I think, okay, what was the point of going up to her? So,
okay,
there's
wait.
a version. Oh, go
I
ahead.
want to back up.
Okay.
If we go back to your version, I think the way it could have been okay is if the therapist said, it's the holiday season and I'm probably going to be doing some shopping at your store. If I see you, how should we handle it?
Yeah.
That's the way, right? If she really had to go in there and there was really a chance that Lilith was going to be there, then I think that it could have been prehashed. And I think that would be totally reasonable.
Or she could have even acknowledged that in the moment and just said, "Hey, I'm so sorry to catch you off guard."
I
But this
guess.
was
But
the
I also
scenario,
think
yeah.
in that scenario, she shouldn't have acted like she knew her. But that's why you
Yeah.
got to talk about it ahead of time.
Right.
But go ahead. Sorry.
No,
I just wanted to acknowledge your better scenario.
Well, when I think about what's the point of going up to her, there's a possibility that the therapist actually thought it would be a treat for Lilith. That it would
sounds
be
like
a
she was
nice
right.
surprise.
In
Well,
part,
yeah,
right?
her
She got
initial
half of the
response, right.
ambivalence correct. Yeah.
But then it makes me think the therapist doesn't really know how this works.
Obviously.
So, and then another idea,
Because
which
I
is
bet the
less
therapist
flattering.
was also happy to see her.
That was the other scenario, which I think is even
Okay.
less flattering, that it's the therapist just really likes Lilith and just simply wanted to see her and wanted her to meet her baby.
I'm going
Which
to
then-
by the Bobby Brown counter and show off my baby. No, it's worse.
It is worse because then it's all about the therapist's needs and
Right.
you can't get those gratified like this. Like you just can't.
We have a theme.
The therapist is challenging the boundaries that she set. So of course, after Lilith was pleasantly surprised, she's left being confused.
Right.
I wondered if like a less nuanced example would be helpful.
Okay.
Like if
Do you
I
have
like if
one?
I take it to a more extreme, so it has nothing to do with Lilith. But let's imagine a patient has sexualized feelings towards a therapist, got good boundaries, the longing gets explored, but then there's this occasion where the therapist is flirtatious,
Yeah.
and so you're sending conflicting signals, and so now the patient doesn't know, the boundaries undermined. This is now no longer a relationship where it's safe to explore things because I don't know
Right.
what's going to happen. Now, going to the mall has not at all. I mean, I was using that to paint more black and white.
No. I think you're right. I think on one hand, that is more black and white. I think that there is something additional that also feels like a pretty hard boundary where the therapist went and pursued her out in the world, right? It's obviously not in the office. It's not on the Zoom. It also, I think, maybe, well, I don't know if the flirtatiousness also feels that way too, but I think it also makes things feel, the physical boundary feel blurry and unsafe. And I mean, I can imagine, working at the mall and then becoming nervous all the time, right? There's a million people in and out of your store, but one of them is the therapist again, right? I mean, I think there's, again, depending on their community, but I think that there is also something like particularly violating here about coming to her place of work, but specifically coming to her outside the confines of the therapy. that is very weird.
Yeah, it reinforces the idea that they probably both share, which is that, yes, we could in fact be friends if we didn't have this professional relationship.
But indulges it without a chance for exploration. I think it makes things really fuzzy, which is the problem.
Yeah.
That, Lilith can't totally know what to expect. The therapist could be there at any time, but then the therapist is going to show up for her own needs, show off the baby, say hi, bye. I'm very curious. Have they had a session since then? Did the therapist bring it up? I mean, yeah, Lilith, I think you ought to talk to your therapist, but I also think it's on your therapist to keep talking to you about this because she already introduced herself and her baby into the situation. And so I think there has to be an at least like, what'd you think when we ran into each other at the mall the other day?
Wasn't it like old friends? Wasn't it just like our friends?
Right.
Because that's the thing, is like she's gratifying the wish. I mean, as Lilith is saying, I wish that we could be closer. I wish that we could be in the family together.
Right. And so it is about transference, but then the therapist acting it out, or sort of, it is like flirtation though. I mean, I think your example is good because she's flirting with the idea. She even brought another family member in. I mean, I think it's a little extra. And they didn't talk about it ahead of time. They definitely need to talk about it afterwards. And I don't know, Lilith. I don't think you seem like a cliche. I think that it sounds like at least part of the therapy was going well before this, and that you were feeling closer and you were talking about things, and maybe you felt more secure in the boundaries. But to go, I don't see how you go forward without talking about it. Maybe is where it ends out, which is maybe too bad because it wasn't your choice, but here you are.
Well, and one thing, if it's important to see each other in person, which I can understand that, like wanting...
for sure.
But if they're still within... I mean, it sounds like they can't do it on the regular, but most of the time it's not either or. If it's once a quarter, maybe...
Yeah, she says it's a tad far away, right? I mean, I've had people drive from out of town. Yeah, quarterly, a couple times a year, something like that. Like, that's
like it's
fine.
It's okay to like try to block off the time and so you can see each other in the office again. If that helps with some of that sense of closeness, so that maybe some of these harder topics are easier to talk about in person. I don't know.
I think so. It's not exactly stalking, but I was trying to think of an analogous situation. If the patient showed up at, I don't know what, the therapist's church or neighborhood or some other sort, some other thing to try to get a glimpse of her, that would also feel weird. It feels like like they're acting like they're friends, but if there was a reciprocal situation happening, it would feel like a major boundary crossing.
Yeah, the rule actually applies both ways.
It does apply both ways, but if you flip it around, I think it suddenly feels very creepy.
Yeah, right. That's what I mean, is like the therapist is getting it her way, but she would probably shut that down really quick. Right. If Lilith decided to pursue her somewhere in a public space.
Exactly. So that's better said. But yeah, you aren't the problem. And I know she didn't specifically say that, but how she frames it, it's like, well, it's all my problem. It's my transference. This is something I wanted. I feel like a cliche. I couldn't help but smile. Like, even that being happy was part of the problem. And I think these are all genuine reactions, none of which are problematic. And I just really hope they can be dealt with so that your therapy can continue.
Yeah, that's a really good point. That Lilith, the attachment you have towards her, it doesn't mean that there's something wrong with you. Did she say that? Yeah, she said the problem is my attachment.
Yeah.
That's actually not a problem. Having the attachment is not a problem. Having those desires is not a problem.
And being attached is actually really helpful.
Exactly. The problem was that your therapist shouldn't have come into your workspace. I mean, that's the only problem that I see here. I don't see your reaction or anything means that you were damaged in some way.
But here's what, I know we always say update us, but I would love to know how the session or sessions went after this meeting.
Maybe she'll gratify that.
Maybe she will. Pretty please.
We'll see.
I know. We don't have it, as Dave says every episode, we don't have a therapy relationship, so it's totally fine that we're asking that of you, Lilith, just to be really clear.
That's right. Well, thank you all for listening, and a special thanks to Tess and Lilith for your questions. As always, we love getting your reviews, feedback, and questions. You can send us an email or leave an audio message at our website, callthepsychiatrist.com, or you can email us directly at callthepsychiatrist@gmail.com. You can join us on Instagram or Facebook at Call the Psychiatrist. And the most important thing we ask is you please tell a friend about the show so we can find new listeners. All right, take care.
Bye.
Do you think she thinks of me or you as Batman in the dynamic duo?
Obviously, you're the sidekick. You have a lot more Robin energy happening.
You know, if I ever was a boy wonder, I'm not sure if that really fits anymore.
You don't think so? I mean,